And we are live.
Welcome everybody to the Thursday night recap of week number 2 for the osteotomy course. Once again, it's Michael Sirkin. I'm the moderator for tonight, and I'll remind you of the faculty who we had on Saturday morning: Maurizio Cafori, Raul Vedia, and Keith Mayo. The beginning of our lecture, we had Maurizio Cafori talk about alternative digital planning software and give us a review of some of the measurements and how to get x-rays from the prior week. If you remember, he showed a long leg alignment film, and this was his case where he did a full-length standing x-ray, and when they measured his correction, he wasn't quite happy with how this looked, and he thought maybe he overcorrected or undercorrected this case. And so we ordered some new x-rays. And when we got the new x-rays, it was dead on the center of the hip, through the center of the knee, through the center of the ankle. So the question he asked himself was why? And this is where the critical evaluation of your x-rays come in. As we heard Mitch Bernstein talk about the previous week, your x-rays have to be perfect. So when we look at this full-length standing x-ray and we look at the patella, you can see that the patella is off lateral. The fibula is hidden behind the tibia, and the ankle is not a good x-ray. So this is clearly externally rotated because of these three identifiers. As we look now at the better x-ray, we can see the patella is in the middle. The knee joint is well centered. You can see half of the fibula, and the ankle looks like an ankle. So when you get these films, rotation of the limb matters, and can matter dramatically. And in the end, the surgery that he did was perfectly right on. So what shall we look at? As I said, the patella was not centered in this case. You can see on the right limb here, condyles asymmetric, no overlap of the tib-fib joint, so the leg is externally rotated. Here you can see the patella is centered, the knee joint looks good, and the fibula is half of the you can see half of the fibula. But keep in mind when we have patellofemoral disorders that this can be a problem even if the patella is centered, because here you can see the patella is centered, yet there is no overlap from the tib-fib joint. So this is not a perfect AP either. So you have to keep this in mind with patellofemoral disorders, as Maurizio showed you. In addition, he showed us leg length manners. You have pelvic obliquity, and Mitch showed this as well, that you want to get your pelvis level so that you use blocks so you can get a good x-ray and avoid pelvic tilt. We looked at Maurizio showed us the mechanical axis, center of the hip, center of the ankle, and once again he reviewed varus, valgus, and then touched on all of the different angles that we should be measuring and be aware of when we're doing this type of surgery. He then showed us some additional software where he's able to measure different angles, and it calculates all of these angles. I'm not going to go over this, but this was Metacad, and keep in mind that all of these softwares need practice to be able to use, including Metacad or BoneSetter or some of the other software. And it was just an excellent review of all of these things that we need to be mindful of. Next, we had Raul talk about how to use the BoneSetter app again and how to use it to look and see what deformity you have. He measured angles in the femoral neck, non-union, malunion. He measured the neck shaft angle. He used the hip center button, as you remember, to not only find the center of the hip, but he also used this as a good way to find the middle of the bones. And then you could use two of these hip center markers, connect the center, and now you have the center of the bone. You can measure the non-union angle of the femoral neck, and he showed that, how much shortening of the limb due to varus collapse of the femoral neck non-union. And overall, it was just a good review of BoneSetter to evaluate the deformity. We then had Keith and Raul go over preoperative planning of an intertrochanteric osteotomy for a femoral neck non-union. Keith talked about generically how to do this, how to use paper and pen, and what things you should be thinking about to take some time to do this. And this is a picture of, on the right here, of all of the tools that he was using. And you can notice that the most important thing is to take your time and really enjoy yourself with a nice glass of wine or a bourbon as you do these planning sessions. He pointed out that when you do these intertrochanteric osteotomy, you don't need to totally correct the Powell's angle of the femoral neck. In the past, when they were done, they only had wires to use and a tension band wire laterally. Now we have much better implants, typically a blade plate, and so we don't have to get the angle corrected fully. Typically 20 to 30 degree change is typically enough. And he showed how to plan using an opening wedge, a closing wedge, or a partial opening or closing, depending on how you do your plan. He stressed the importance of trying to put one limb of the osteotomy transverse to the horizontal plane of the femur, because that's a much easier osteotomy to cut, perpendicular to the long axis. It also allows the angle of the blade to be 90 degrees plus the angle of the osteotomy. So if you want to do if you want to do a 20 degree osteotomy, you use a 110 blade. Because it's 90 degrees for the blade and 20 degrees for the osteotomy. If you put it in perpendicular to the shaft, you'll get a 20 degree correction. And then regardless of what angle you want to correct, you always try to do it in increments of 10. You don't do a 22 degree osteotomy or a 31 degree osteotomy or 27. You're going to use 10, 20, 30, etc. He talked about offset compression. And after you draw correction, make sure your blade fits on your montage of what you're trying to accomplish, so that the shaft isn't too lateral or medial and the proximal segment fits where it belongs. We then saw Raul use BoneSetter to actually physically draw a plan, tracing the bone. He shows how to cut the bone, move the bone around, whether it's rotational and a rotational tool, or translation, moving it proximally distally, and then cutting out your osteotomy. He then showed you how to compare the construct to the other side, group different things together, again, try all the implants, and then finally measure the length of your cuts, your blade, your osteotomy size, the size of your wedge, all done in BoneSetter to plan that. At this point, what I'd like to do is I'd like to ask Keith to go ahead and show us the pre-op planning for the femoral neck non-union as he did on Saturday.
Okay, so here's our case from last week. And we've gotten, I'll back up one more slide. So we have an AP, and just to emphasize the difference between the pre-op normal that you're going to use for the hip is different than the full-length alignment film. And that is, this should be a spot x-ray of the hip to at least the proximal third of the femur, and preferably it would be internally rotated to give you an exact projection of the AP of the proximal femur. And that would take into account the average aneversion, which is 10 to 15 degrees in females and somewhere between 7 and 10 degrees in males. So again, you can't use a full-length alignment film, cone it down, and hope to get an appropriate CCD or neck shaft angle. So we'd start with that. We have a lateral, which in this case is almost, shows no evidence of retroversion. This is unusual for femoral neck non-union. Most of them are retroverted a little bit, but we can eliminate that unless there's a native version problem. So if we know on the other side, this person has 5 degrees of retroversion and now they have a femoral neck, then you may want to correct that with your plan. But for this point, we're not. So there's our pre and post-op or post-ops late with 3 broken screws, which are going to have to be taken into consideration for the plan. And then we have a normal. And that normal has a CCD or neck shaft angle of roughly 135. Normal's a broad between 120 and 40, 120 and 140. And then a frontal plane axis in this situation of between 105 and 110. I think you can make an argument this should be closer to 105, but that gives us a 25-degree difference in the frontal plane. And then we're going to overlay them. And this is probably the critical part of the plan because it's going to give us a frontal plane correction between the normal axis and our deformed axis. It's going to give us a leg length inequality, and it's going to give us an estimate of offset. Now, of all of these determinants, the critical determinant is leg length inequality. People are very unforgiving if you leave them short. The range of CCD angle is relatively much larger. So if I had the choice between accepting residual shortening of a centimeter or even a half centimeter, I would always pick a plan that would give us the ability to equalize leg length. The frontal plane correction has a much bigger sweet spot, so to speak. Offset is relatively restricted, and if we want to increase offset in a way which doesn't deform the proximal femur, then that frequently requires a trochanteric transfer as well, and that significantly complicates planning. So then we're at the end, we have all of those parameters, and now we're going to configure the osteotomy, and there are a variety of different 30-degree closing wedges. You see one that's oblique in 2 planes relative to the shaft axis, and that's one. And then the easier one is one that has a transverse or orthogonal limb. And then we can go to 2 segments. I prefer to do it this way, and you can do it this way with BoneSetter. You have 2 segments, and then you can approximate the lateral cortex, which is, I think, a good place to start because we really don't want shaft displacement in these reconstructions. And then you can go to the 3 options, the extremes, meaning opening wedge, combined opening and closing, and pure closing. And in kids, certainly we can get away with pure opening wedges because they'll heal things rapidly. In adults, we try to avoid that. Usually the most versatile is a combined opening and closing, and it can be usually halfway across or 2/3 of the way across, and those are relatively easy to plan. And then at the end, you should have a deformity correction at which you'll be able to overlie that on your implant. And this is a situation where you probably could use either a 110 or a 120. You do not have to be perpendicular to the now reoriented non-union plane. And so this is what we decided to use with the 120. And then we'll take that and now reconstructed femur, overlie the proximal segment, and then draw in the seating chisel path. And this is a critical part of it that is going to enable you to execute your plan the way you intended. And then at that point, you're going to go back and go through a series of reference Kirschner wires, usually mandated orthogonal to the longitudinal axis, another soft tissue K-wire at the tip of the trochanter, and that's going to be the measure to the base of the seating chisel placement. And then there should be another interval between the osteotomy itself and the distal portion of the seating chisel. We like to preserve at 1.5 centimeters wherever possible. And then at that point, you should be able to then use additional K-wires for security, for determining what your correction is going to be. So in this case, it was a pure closing wedge. And then you have a reconstruction and your original deformity. And then at some point, since we can't tension high angle blade plates without theoretically pulling the plate out of the proximal segment, so the articulated tensioning device usually should not be used in these beyond 100 degrees. So 95 and 100 degree blades you can use it with. Beyond that, it's at least theoretically a problem. So you're going to do compression by mismatch. Now, this is an old school drawing where it was thought to be useful to have a unicortical screw at the end of the plate. That's never been borne out. So that would be usually a bicortical screw in holes 1 and 4 as the final construct, which is what you have here. So I just want to reemphasize the fact that how much residual offset you can tolerate is dependent on age. So if you're going to lateralize the shaft on an oblique osteotomy to make up for leg length in a really short femur, then you better be doing that in an adolescent or somebody that has a long time to remodel the lateral cortex. Because if you have a canal which no longer lines up with the epiphyseal metaphyseal segment, and it comes time for that person to have a total joint, they will be cursing you and they'll be saying bad things about all attempts to save joints for the rest of their careers. So I can envision easily putting a femoral stem of virtually any design in this proximal femur. And I think that's probably the overriding consideration. I would never, at this point in history, ever go above a CCD or neck shaft angle of 140. It's just not necessary. And that has certainly implications with regard to where you put the shaft relative to the metaphysis. So when you're done with that, then the key thing is, and Roger Wilbert's going to talk about this on Saturday, you need a detailed, essentially game plan for everybody in the OR. I usually put these up in advance so that everybody knows, and I'll actually review them verbally, and that includes going over things with the anesthesiologist. We usually use epidural generals, but you can do whatever you want. Position, supine versus lateral decubitus. I started early supine. I much prefer lateral decubitus. Roger will talk about that. And then you want as much detail as you think you need with alternate steps in that surgical technique to accommodate what you think are going to be the potential errors that occur. So you want to have plan A, you want to have plan B, and plan C if something goes wrong during your execution. So with that, I will, or Michael, do you want to turn it back over to Raul?
Yeah, you could stop sharing your screen.
Yeah.
So what we're going to do now is we're going to have Raul take us through with Keith the practice cases from the weekend.
Okay, can you guys hear me?
Yep.
Yep.
Okay, so this is this is Brett's case, the one that you guys all did, and about 100 of you did it, and you did a very good job. This is an example from one of the participants who did a really good job of measuring the Powell's angle, the CCD angles, and the leg length. And these are the numbers. We'll post these for your answers in the on the YouTube channel. And most of you did a very good reconstruction. And you can see here that, as Keith said, the height is reconstructed. This is about a 30-degree change. This is also an example from one of the participants who made a partial closing wedge. And again, I think, Keith, what do you think of the offset? Is that looks like it's almost dead on, but I think it'd be pretty hard to put a stem of a hip in that. Keith?
Yeah, I agree. I probably at this point, I'm sure I had cases like that early, but I probably would have not lateralized the shaft as much. And you can imagine that you're going to have problems reestablishing a canal for any standard shape stem to fit in there. So I would never accept at this point more than 25% shaft offset in most cases, and those are in adolescents. Now, if you're in a really young patient and you're going to do a trochanteric lateralization that give you essentially an expanded metaphysis, then you can pick up more length. And those are more useful for other types of deformities. But if you look at those femurs at 5 years, it's hard to tell that anything was ever done to them because they're so effectively remodeled. But that does not happen in adults. And so I think we have to plan for the next operation. And the next operation, if something goes wrong or this joint becomes arthritic, the next operation should be a relatively routine total hip. And that's what we want.
So I like the plan. It solves all the issues that we talked about. And one issue that we didn't talk about was what Keith just said was, what are we going to do next? So you certainly could have a little shorter leg length and bring the shaft and medialize the shaft back to where it was. But otherwise, this sort of plan did accomplish what the goals were and didn't accomplish the secondary issue. Now, here's Keith. Keith gave us 3 examples, and Keith, this was your second case. Keith? Oh, Keith's on mute. Keith, I think you're on mute.
Okay, all right, back.
Sorry. So this was someone's plan from the second case that you put up there. It was your second case, and I thought they did again a really good plan. They even did a Powell's angle. It was a kind of a basy cervical fracture with a cutout, and then they did this kind of thing, and again got the length almost right, almost exact, and got the angle again pretty good. But again, we talked about the lateralization of the shaft.
Yeah, I think it's a very similar case. This is in these situations, in order to completely equalize leg lengths, then you have to end up with a bigger opening wedge than closing, and then you have to usually take the resected lateral closing wedge and reverse it medially and hope that it incorporates. The other thing you can do in younger patients is that gap between the proximal portion of the blade and the base of the trochanter. In a younger patient, you can fill that in with the triangle, or you can take other bone, and in kids, that will fill in and remodel. That when does that end? I don't know. I mean, I've tried it in adults, and it's very spotty as to how much actual remodeling you get in adults. So this, again, would make me a little nervous in terms of failure. Now, the only other option is you can say, well, screw it. I want the best looking femur, so I don't want to bring the trochanter below the center rotation of the hip, and that's been done nicely here. Just say, okay, so if this fails, then what that's going to obligate is going to be a 2-stage total hip. It'll be essentially, or you can do a 1-stage total hip. You can do another osteotomy and use the stem and a lateral plate for fixation for the femoral component. But I think in general, if it's possible, we want to try to give ourselves a medullary canal that can be established. Okay, it's not going to be straightforward. You'll have to drill it and open it with some other techniques, but at least the metaphysis aligns with the canal. And it would be hard to say reproducibly looking at this say it lasts 5 to 10 years, we don't know what it's going to look like, but we have to plan for it.
So I don't mind the offset from the GT where the blade starts, and there's certainly enough space from the blade to the osteotomy. And you know, as you've shown, you can make this osteotomy shorter or longer, and that will change the whole geometry of your osteotomy. And you can play with that a little bit. Now, here's someone else's. What do you think of this one?
Yeah, it's incrementally closer. And I think that, you know, the only obstruction probably here would be if that gap didn't fill in. So you'd have to essentially broach, you know, if we go to, here, you know, if you can imagine a broach coming down here, you're going to have to reestablish this, and hopefully this would have filled in. So.
Okay. So as you can see, and this is a shorter osteotomy and a little bit more of a wedge taken out, as you can see, and that changes a lot of the geometry that we're talking about. So the other thing I liked about this plan was they did what you said. They actually put down a plan of how they would do it and the angles, and they had some nice K-wires on the rest of the plan where they would put it measuring off from the GT and going down. And then this was your plan, which we talked about. And again, the canal is reconstituted. I'm a little concerned that maybe the leg length wouldn't have been exactly the same as the other side, but certainly this healed and it looks fantastic.
Yeah, I can't remember what leg lengths were, but it was close. And I think if you're, so it's almost impossible to over lengthen. But I mean, being within 5 millimeters should be the goal. And if the longer they've been living with a deformity, the more they're going to notice an acute change. So I think that there are a variety of different ways to do this. I'm even a little concerned about this being, okay, so the problem is with a lot of femoral neck non-unions is the neck is actually short, and you're going to see one of those cases on Saturday. And so if it's too short, then you have problems with mechanics because the abductor moment arm is lost. And you also have the problem with impingement. And that is to some extent dependent on the horizontal plane. So if you look at where this is, I think, a weight-bearing film, but if you look at the hip center relative to the tip of the trochanter, that is not a normal anatomic relationship. Those mild valgus, and certainly it is possible to overpressurize hips like this, and if they're have any underlying arthritis, you can accelerate that by going too high.
So these are topics that you guys are going to cover as we go through this. Yeah. I think they're all, I mean, they're great points. Should we go to the next one, Keith?
Sure.
Okay, this is Keith's third case, and this was a Jeff Mass case. And here's a nice measurement done by one of the participants. I thought they did a really good measurement of the neck shaft. Tough place to do it up here. And you can see, like you said, the other measurement from the center of the head to the GT, very varus. I thought they did a good measurement for similar to what I got. And then here's a couple of examples of how they attacked it. What do you think, Keith?
Yeah, so now this is the bridge to Saturday's talk. So we've moved away, we're slightly more distal now. So this is an intertroch mal/non-union. And so our goal now is to be as close to anatomy as possible. And there again, leg length is probably the primary determinant, and mechanics is still important. I think we have the same problems with offset that we've talked about before on the left, and the right is in general probably much closer to where we would want to be. And, you know, the question is always, you know, how distal we would in general probably like to leave a lesser trochanter intact functionally. And we don't really know in a given hip how important psoas power is, but we try to not involve the lesser trochanter in the osteotomy itself. I think on the left, we have similar corrections, but probably too much lateral shaft offset. We got 50% lateral shaft displacement. And on the right, minimal amount. And I think that's probably closer to where we want to be overall.
Okay. Certainly different options for the level of the osteotomy and the amount of osteotomy that you take away. You can experiment with that. That's one good thing here. When like you guys always say, you can always throw away the paper and start again. Here you can just go backwards and start again, or do another one, and do several before you're done. Here's a third one, which I thought was a little bit more anatomic, and again a fairly large piece taken out. I just an example. This is what Jeff did. Keith,
Can we go back one there? So if we're looking at this, is the osteotomy, this transverse osteotomy. I think that the one thing that you can't do, well, or you have to do with extreme caution, is that if you sacrifice the bridge between your blade plate and the lower part of the metaphysis, then your ability to maintain correction in here is going to be lost. So if you wanted to use this configuration, you probably would have started with a higher angle insertion. You would have come up here with a lower angle blade plate. We would have started higher in the trochanter. Let me see if I can do this. So I would have started, the blade would have come in like this.
nice.
That's not working.
No, it's working. I can see it.
Okay, so I would have started with a lower angle blade plate and started much higher, and that would have changed the entire plan, but it would have given you an intact bridge between the lower part of the blade and the metaphysis. Why do you need that? Well, you don't always have it. So if you're going to do a trochanteric transfer and you've cannulated the trochanter and it's going through a metaphyseal aperture in the proximal segment, you don't really have it. But you just want as much intact bone in the situation where there's no cortex sort of buttressing the blade as opposed to cancellous bone. So, I mean, I like the shape of the femur, so that would have been fine if a different implant had been used and incorporated into the plan.
Okay, sorry, we only gave him the one blade. Maybe we should give him some options.
Yeah, I think it's, and this is off-label, so, and there are cases where, for instance, in this case, if you look at the left side, somebody really stacked this side plate with 4 screws, and predictably the failure would never be in the side plate. But then you have to decide, are you going to bypass the distal stress riser? And sometimes there'll be a second level of deformity, and all of your blades are only 4 holes long. And so the only way to then compensate for that is to take a 95-degree plate in an off-label fashion and recontour it to whatever angle you want. Usually you'd go back to something known, 110 or 120 or even 130. But then you can have a custom osteotomy plate, which doesn't have quite as much offset because the distance between the medial part of the side plate and the lateral portion at the bend of the plate isn't quite as much. So you have to plan more as far as how far you're going to insert it. But then you can make any kind of plate you want. And
Keith, you're saying that the 120 and 110-degree blade plates are usually only 4 holes, but the 95-degree blade plates, we've got longer blade plates that we manufacture.
Yeah, they go to 18, so you can do virtually anything, 18 holes. And so all of the osteotomy plates, and that includes the 90, which have high offsets, 10, 20, 10, 15, and 20 millimeter offsets. And then the 100, 110, and 120, 130, all of those are only 4 holes. So if you've got a subtrochanteric component, you're going to have a hard time using that implant for fixation.
Okay. And then what did Jeff Mass do here?
So this was I think, a combined technique where I think he actually had 2 oblique osteotomies. And the goal again was to reproduce normal anatomy. Well, it's a little tough to do that when the trochanter is involved. So in this situation, you're not going to have a normal looking trochanter, and you have to think long and hard about whether you want to try to increase the difficulty of the exercise by then moving the trochanter as part of the procedure. In this case, it was elected not to. This is about a 15% shaft translation. And then you can see a detailed surgical tactic. And I put this in because I think it's an elegant solution, but more importantly, it underscores the fact that probably one of the more brilliant surgical tacticians and technicians in the last 50 years never felt that he was at the point that he could do this from memory or without a careful plan. So there is a tendency to sort of acquire skills and then think that everything is motor memory and that you can just go essentially freelance it. But in situations like this, I think even if you've done 20 of these or 30 of them, it is critical for you to understand where things can go wrong. I've had to there are times when I put a blade out the anterior part of the neck and had to convert to a locking plate intraoperatively. So I mean, I think it's critical that you think about where things can be problematic and have thought about them before they occur. And if you've thought about them, you'll prevent that occurrence.
Very good. Let me just...
Okay, I thought that was great. I just want to bring up the summary and take-home points. We saw for the whole session. We saw some alternative digital software in Medicad that Maurizio showed us. We just heard pre-op planning helps minimize intraoperative complications, even in what I would consider expert surgeons and surgeons who've done many of these, like Keith and Jeff Mass. They always did pre-op plans. Keith continues to always do a pre-op plan because it's critical to understand what you're trying to do. And the pre-op plan helps you visualize what you want to do. It lets you try different things, and it allows you to practice what you're trying to execute. I think I'm going to ask the first question here of Keith, and what I'd like Keith, Raul, and Maurizio to do is to, you can all put on your video as well. I'll stop sharing and we'll let you guys come on. And I'm gonna come off. So Maurizio, you can come on as video as well. But my first thing I want to point out is how subtle changes in the osteotomy really do have a major effect on the reconstruction. And that's what I believe you guys are playing with, all 3 of you, to get the hip to look like what you want it to look like in the end, whether the offset's right or whether there's a canal. My question to Keith is do you ever, at the end, after you've drawn your reconstruction in an older person, do you ever then take a hip template and lay it over to see if you would be able to convert to a total hip later? Or is it just a gut thing from doing enough of these?
Yeah, in 2 cases, including the one that was shown as the preoperative planning exercise, that was a 54-year-old female, and she was planned for a total hip during the same surgery if I had to too much difficulty getting the screws out and had done too much damage. So we discussed that in advance. She didn't want it, but I told her it would probably be a better idea. So in 2 cases, I've actually planned and had total joint components in, not open, but available as a bridge. And you know, that sort of leads into discussion of what the surgical approach is, which Roger's going to be talking about on Saturday. But I think that he's also going to talk about when you should do it. I mean, when is it appropriate? What's the age cutoff? And but I think you, in the back of your mind, in a young person, you should be thinking about, will a stem fit? And certainly it would be not a bridge too far to think about overlying a template. And that would certainly give you some peace of mind that you're not going to be cursed in 10 years by a total joint person saying, oh, what a ridiculous operation this was.
So Keith, what I meant though is someone who you're not planning on doing it. Let's say you have a 60-year-old that has a good hip with the femoral neck non-union, and you're not planning on doing a total hip as a bailout. But what you want to do is you want to make sure that whatever you do as a reconstruction, maybe 5 to 7 years later, 10 years later, if it fails, if you can do the hip, do you take your reconstructed montage on paper and maybe lay a hip template on it, just to make sure you're not too laterally translated with your shaft? Or is it just something from doing these enough that you've looked at and know, hey, that looks right?
Yeah, I think that's a great idea. Unfortunately, I've never done it myself. I guess it's because I think I know where most metaphyseal fit stems lie anatomically. And I think the key part of this, which I haven't really emphasized enough, is that in addition to the AP, you can have major problems on the lateral if you have any translation of the shaft. So you'll end up putting the stem out, typically anteriorly. So we sort of neglected the lateral, assuming that the metaphysis will perfectly line up with the diaphysis. And that clearly has to be underscored as well, because we've been planning in one plane for a 3-dimensional problem. And I think that's good. So to answer your question, no, I haven't done it. Should I have? Probably. And I think it's a great idea just to make sure that you have room for whatever your stem du jour is.
Okay, here I have a question. It says, where do you prefer to do the osteotomy in relation to the lesser trochanter?
Okay, so in general, we would love to be cranial to the most cranial part of the lesser trochanter, and that's to preserve the psoas. And it also is related to time to union. So we know from virtually every other either fracture or osteotomy at the subtrochanteric level, they take much longer to heal. And it also is to some extent related to the compressible surface. So you have a much bigger osteotomy surface in terms of transverse dimension at the intertrochanteric, meaning just cranial to the lesser troch, than at the lesser trochanteric or diaphyseal level. So there's, the considerations are preserving the psoas. Most people still think that's a useful motor group to preserve. Secondly is healing. The second is the osteotomy surface and the ability to do mismatched compression. So the problem that most people had in their preoperative planning was that they felt a bit skittish about not doing pure closing wedges. And so the more opening wedge you become, meaning the shorter the closing wedge is, the more critical it is that you be able to generate mismatched compression. It doesn't have to be a very big surface, but if you're asking the blade plate to counteract a bending moment in a construct which is not load sharing. So the key part of that end construct is the plate is a load sharing device because you've tensioned the plate bone construct. So the compression across the metaphysis is absolutely critical. And of course, it looks better if that's the full width of metaphysis. But even if it's only a quarter of the width, it's still extremely useful. And you really have to spend enough time at the end of the case to generate that compression. And in those situations, I think it's much easier to be comfortable that the medial defect in an opening wedge is going to fill in than a lateral defect with a lateral shaft translation. Because we generally see the medial defect fill in whether or not you reverse your bone graft or not. And it's very, very difficult to predict whether or not you're going to fill in a gap between the lateral cortex of the metaphysis and a translated lateral shaft.
Thanks, Keith. That was a very good explanation. Raul, I don't know if you saw my chat. Could you maybe quickly show the grouping tool again?
Yep.
And there was a question about using BoneSetter. Somebody tried to get it and use it, and they weren't able to. So maybe you can go over how to do that real quick.
Okay, so just a couple of things I want to show you. This is something you drew and you put a plate on, and you try and grab this screw, but you can't grab this screw because it's behind the blade plate. So there's a couple of tricks. All you have to do is go over to items, and if you pick that screw, now you can grab it, and also you can move it forward or bring it forward in your plane. So now it's in the front of the 4 or 5 objects. So you can always move these things back or forward here in the items. So if you can't grab something, it's because it's behind another piece. Now, the group tool is simply if you go to group and you pick and you encircle the objects, it should group them together and move it. Now, if you're not having really good internet access, or like I tried to do it with the Zoom and the BoneSetter together, sometimes you're not getting enough internet access to, or Wi-Fi to, or bandwidth. Terms messed up. Bandwidth to do something that's connected to the internet. Most of the time when you download a BoneSetter case, it downloads completely on your computer, and you should be able to do it. But I've noticed that there was a couple of glitches in the group tool. So try it again without the zoom on, and it should work. The last thing, Mike, how to get to BoneSetter? Okay.
How to get the real version of BoneSetter.
Okay. So if you go to DetroitBoneSetter.com, log in, you can sign up. So if you go to the website, DetroitBoneSetter.com, it says user login, go to sign up, put in your information, and it should send an email. Sometimes the email goes to your junk, but if you're having trouble signing up, there is an email to send information to. You can even send it to my email, which is let's put it at contact@DetroitBoneSetter.com, or you can email me and I can forward it to our programmer. He'll let you on, but it's working pretty good. I did this with Rafi this afternoon, and he seemed to get on. They send you a confirmation email. Sometimes it's selected by your own mail to go in the junk folder. Just check in there. But it'll come back from contact.DetroitBoneSetter.com. And this is a free app. I'll just go back. So you can use it, and it'll go to BoneSetter, and it'll allow you to enter X-rays and fluoro shots. There's projects and case templates, like there's an ankle fracture template. So, all the tools come up. There's a bunch of different tools. Hips and knees are on there as well. It's getting more stuff all the time, but that's how you get on DetroitBoneSetter.com.
So I would say I would recommend anyone who hasn't tried this or doesn't have access to another digital templating software to try this. You can try it on an iPad. Raul is very good at doing it on a computer. I prefer to do it on an iPad. I use a pen. And you can try to start with something simple. Do an ankle fracture, do a humeral shaft fracture, and get facile with it. It helps you play with the cases. It's a good way to plan surgery for those people still in the earlier phases of learning. And I see we have some of them logged on. It's a nice way just to practice doing cases, especially right now while you're probably not doing as many cases as you'd like to do. There's one more question here that I'd like to ask you guys. And the question was when you do lateralize the shaft, it decreases your offset. And the question was, what was the functional outcome of that?
Well, okay, so it goes back to, so when you lateralize the shaft, you're actually increasing offset. So if the concern originally was, say, is a valgus hip, and depending on version, you're worried about ischiofemoral impingement, which is one of these rare things that occurs. Actually, when you lateralize the shaft and your osteotomy is above the lesser trochanter, you're basically
Right.
increasing offset. Okay, and so offset considerations are important if you're taking a normal neck shaft or normal proximal femur, at least theoretically, and going into varus for some other condition, or going into valgus. So in those situations, if you were going to take a normal CCD angle, and for some reason it would be very rare, you want to lateralize the shaft, and you would have, I mean, if you go into abduction or valgus, you would want to lateralize the shaft, at least theoretically, because it changes the mechanical axis, i.e. it changes where the weight-bearing line traverses the knee on its way to the ankle. Now, since we're not dealing with normal anatomy, we're actually going from a deformed proximal femur back to normal or close to normal. And I don't think any of those considerations for displacement of the mechanical axis pertain. And that's been a confusion that's persisted in the literature since the beginning, is that, okay, we're going to go to an abduction or valgus osteotomy, and so we automatically have to laterally displace the shaft. I think that's just a misunderstanding of actually where the mechanical axis lies in its deformed position relative to where it ends up after you've reconstructed the femur. And even having said that, and having done a lot of osteotomies, I have never seen a case, with the exception of somebody who has a marked valgus knee, where changing the shaft relative to the epiphyseal and metaphyseal segment has overloaded either compartment of the knee. And maybe if we had Bob Taiji here, he could correct me on that, but I just have never seen it. So if you have a valgus knee, you might be a little bit more sensitive to it, or if you have a varus knee, you might be a little bit more sensitive to it. But in general, we don't worry about the mechanical axis when we're correcting the proximal femur toward normal.
Can I bring up one point that Maurizio went over yesterday that I thought was really, or during his on Saturday, that I thought was really important?
Of course.
Okay, I'm going to share my screen again, and let's go to, of course, get rid of all this stuff. This one. So Maurizio showed us something that I really like. And you know, when you're measuring the anteversion of a femur, everyone is really good at doing the posterior axis of the distal femur, because you can just go along the posterior condyles. Like some people use the widest part, the interlaminar line, but most people use the posterior condyles, right? And that's not too bad. But then when you go to the femur, it's not that easy. You know, if you're drawing a line, you don't know whether you should go like this or if you should go like this. Like, where is it exactly? And he really showed something that actually that one of our guys also uses, Bob Taiji, uses all the time. And I wanted to just show you how you can do it and where it's important. And you can take another cut. And, you know, we're really lucky here because both the femurs and both these areas and both the knees are like on the same cut, which like never happens. So don't think that's going to happen for you. You're going to have to, you know, cut these out separately. So this is just at the lesser trochanter. And this is what my partner Bob uses. And what you do is you bring that over and you line it up exactly with the lines of the CT scan. And then you can put another hip center. Let's go to this one. Whoops, that one. Let's go to that one, that one, that one, that one. 1 second, and that one. And you can see if you center these areas, then this gives you a line that's way better than what we were talking about before. And it's a very reproducible thing. And between people, if you do it over and over again, I think that's a really big point that Maurizio made on Saturday for measuring the femoral angle.
Why don't you go ahead and show us that one more time? Start from scratch.
Okay.
Sorry to put you on the spot like that.
No,
So
no,
are you doing 3 cuts or just 2?
I'm doing 3 cuts.
Yeah, okay. That's what we want to know.
Yeah, we want to, it's 3 cuts. And what I did was here it is again. And so, like I said, we're kind of lucky because all of my 3 cuts here are like both legs are at the same spot. And that like I said, it never happens. Usually you have to do a separate cut for the right and the left, and you'll have to probably do a separate cut for the right and left. And then here, there's a tool that we have on BoneSetter, which makes your X-ray transparent. So like if I laid it over, you'd be able to see through it, but you can make it transparent. And I usually use 50%, and then I can bring it over, and you can lay your new X-rays over your old X-rays. You can do that too. But then what I'm going to do is I'm going to line that up, and as long as you haven't rotated anything, this should work out just fine. And then what I'm going to do is I'm going to put my center tool back on these points. Maybe I'll just blow this up for you. I'll put my center tool back on the center of the intertroch area. There we go. Maybe right here, maybe right here. And now you can see that you have 2 points. And if I really want to do this, I can bring my femurs down over here. And now I can make the angle between my 2 hip axes and my posterior condyle of the femur. And that gives me a much more accurate anteversion measurement. And remember, like when you do an anteversion, as long as you just do it the same on both sides, that's what matters, that you're just doing the same line on the left and the right. And that'll give you the best accuracy for measuring rotation. Because there is a 5 to 10, there's, between people, there's almost a 5 to 10 degree variance in how people measure this. That's a lot of degrees. But if you can keep variance between yourself very low, between left and right side, like how you measure it, that'll give you the best tool or the best answers. Maurizio or Keith, any thoughts?
No, I think that's great. I think that's a really good way to measure torsion of the femur. And it's very helpful to be able to do that when you're using digital planning. And so you can only do this with digital software, so you can change the transparency of the images so you can see overlay. I like the way you use the hip centering tool, and you've got the center of the femur and the center of the head. And I think that's a great way to go ahead and measure torsion, anti-torsion or retrotorsion of the femur, and compare it to the other side. So I thought that was really nice. We're getting out of time now. It's just almost about an hour now. So why don't you unshare your screen, and we'll finish up and go from there. So we're going over some questions. As we said, you can access the recordings after the fact. You get it through Zoom at 24 hours. In addition, you can go to the AO North America YouTube channel. This is the North American AO North America YouTube channel, or this is a YouTube, and you can just, I want to show you what we have in there now. So you can go to AO North America, and that will, if you search in YouTube, go to the North America YouTube channel. And then you can either select over here, AO North America, or you can go to different channels. Select the AO Trauma North America, go to playlists, And then you can see here osteotomy course. It's still in the top left and probably will stay there because I keep adding more. And what we have now for you, if you look here, is we have week 1. We have Ask the Experts from week 1. We have why the legs are shaped the way they are. We now have week number 2 as well in there. In addition, we have all the practice cases from week number 1, RV case 1 through 1, 2, 3, 4, 5. Actually, we have 2, 3, 4, and 5. We don't have 1. We have the rotational ones from Mitch, and those are MB case 1, 2, and 3. We'll get the new ones up from that we did today. But in addition to just having week 2 up here fully, we decided that we would break out the individual lectures for you if you just wanted to watch Raul do Understanding the Deformity, or Maurizio reviewing or doing digital planning, or Keith or Raul doing their component, so that you won't have to search inside of the video. So we're trying to give you as much access as we can to make it easier for you to continue with your learning. So this Saturday at 11 o'clock Eastern time, we're going to be doing femoral neck non-union, when to address and how, and that's going to be Roger Wilbur. We're going to hear from Keith again on osteotomy options for femoral neck malunions. Mark Riley is going to talk to us about pertrochanteric malunions, the indication and techniques. We're going to hear from Mike Miranda on rotational deformities, indication and techniques. And then Brett is going to run an expert panel case review, and we'll have some question and answers around that as well. These are the faculty that you'll see this week on Saturday. And so I hope everyone and encourage everyone to tune in as we continue doing this thing. So this osteotomy course, this concludes our Thursday night Ask the Experts and recap. Thanks for everyone for attending.